And you're live.
Great. Welcome to those of you who are just joining us. Just hang tight for a minute while we let other folks log on. Welcome to those of you who are just joining us now. Just hang tight for a minute or two. We're going to give people a chance to get logged on. Welcome to those of you who are just joining us. Please just hang tight for a second while we let other folks get logged on, and then we'll go ahead and get started. All right, I think I'm going to go ahead and get started. Hi, everyone. For those of you who I haven't met yet, my name is Hilary Godwin, and I'm Dean of the UW School of Public Health. Welcome to our first webinar of 2021. Thanks to all of you who provided feedback to our webinar survey. So we're going to, based on that feedback, we're going to continue to hold the webinars bi-weekly, and they will continue to focus on the universities and the schools' response to the pandemic. But there's also space where we'll be highlighting some of the amazing work that's being done by folks in our school, not just on COVID-19, but also on other important public health priorities. Today, we are going to discuss the COVID-19 vaccine distribution in Washington State and at the University of Washington, as well as Governor Inslee's new Healthy Washington Roadmap to Recovery plan. Before we continue, I'd like to acknowledge that even though we are meeting by Zoom, all of us are on Indigenous lands. And in Seattle, where many of the folks on this webinar live and work, we recognize that we're on the land of the Coast Salish people, the Suquamish, Tulalip, Duwamish, and Muckleshoot nations. We honor the people who are still here and on whose land we are guests. These webinars are designed to keep the community informed and connected as we work and study remotely. We welcome any alumni or members of the UW community who are joining us today. While anyone's welcome to take part, just to be clear, sometimes I'll offer specific comments about what we're doing in terms of workplace policies, and those reflect what's going on in the UW School of Public Health. So if you're not primarily in the School of Public Health and you're just here as a guest, totally fine. But you might want to touch base with the head of your unit to find out what the policies are in that unit. Also, as a housekeeping function, just a reminder, we use the Q&A function for answering questions. We're going to try and leave lots of time for us to be able to answer your questions at the end. So please put those in the Q&A box. We don't use the chat function for that. We use the chat for, like, if we want to share a link to a resource or a piece of information that we want everyone to be able to see. So don't put your questions in the chat box. And if we see them there, someone will probably ask you to move them over to the Q&A. So with that, let's go ahead and get started. So we're delighted to have with us here today Janet Baseman, who's our Associate Dean for Public Health Practice and a Professor of Epidemiology and an Adjunct Professor in Health Services. And also Timothy Dellit, who's a physician and Chief Medical Officer at UW Medicine. and a professor of medicine and infectious diseases at the University of Washington. So our plan for today is I'm going to give a really quick update on the state of the pandemic and the impact on UW and SPH operations. And then we'll head into an overview of sort of where we are in terms of vaccine distribution. I'll provide a general overview for the state, and then we're really happy to have Tim here today, who's going to talk about what's been going on at UW Medicine, who's been one of the critical early vaccine providers. And then we'll do a quick update on what's up with the new phases with the Healthy Washington plan. And then we will leave lots of time for questions. Okay, so to start, as always, our hearts go out to those who have lost loved ones due to COVID-19 or who have loved ones or friends who are currently struggling with the disease. It's astounding to look at the statistics, but even more heartbreaking when we think about that these are individual people who are loved and missed. So far worldwide, there have been more than 91.8 million confirmed cases of COVID-19 and more than 2 million deaths. Nationally, we've recorded more than 22.8 million cases and more than 380,000 deaths. Here in Washington State, the Department of Health is currently reporting more than 266,000 confirmed cases, over 16,000 hospitalizations, and nearly 3,800 deaths. Closer to home, at the UW Seattle campus, Environmental Health and Safety has reported that we've had over 1,120 COVID cases. About 82% of those cases have been students, with 36 cases reported in the last 10 days. These are numbers that include positive test results reported to the UW by UW community members, in addition to those that the results that we have from our new Husky coronavirus testing program. But they do not include UW Medical Center employees. Those are reported separately. You've probably all heard in the news that two new variant strains of SARS-CoV-2 have emerged in the United Kingdom and in South Africa. Here I'm going to quote Jeff Duchin, who, as is often the case, put it best, which is that the variant strain spreads in the same way as the other strains. It's just better at it. We're still waiting to find out how easily this variant is transmitted, and whether currently authorized vaccines will continue to protect against it. The initial results on that look good, but in the meantime, it's really important that you continue to wash your hands, wear a mask, and limit your physical interactions with people outside your household, particularly keeping that 6-foot distance. So with that, I am going to turn over our discussion to the conversation about vaccine distribution, which I'm hoping is going to come up here. All right. I'm looking at Janet. Janet, does it look good? Can you see it? All right, great. Okay. So these slides will be made available on our website, as is the case for our prior webinar slides. So I included in here some of my favorite websites about vaccine information and distribution, really good resources of references. And please note, last but not least at all, at the bottom there, a link to UW Medicine's Q&A page. It's a really great page, and particularly for those of us who are located here at the University of Washington Seattle campus, a really great place to keep checking. I also included useful resources and references just about COVID more broadly. So where we are today is that we have 2 vaccines that have been approved by the US FDA for emergency use authorization. They're both mRNA vaccines, one by Pfizer BioNTech and the other by Moderna. They both have about the same efficacy, about 95% efficacy, and both require 2 doses to achieve that level of efficacy. As a reminder, the process for big picture process for distributing COVID vaccines in the United States is after the FDA approves vaccines for use, that the federal government, the CDC, has contracted with vaccine suppliers and determines what the allocations are to each state. The state health officers order vaccine doses and indicate where they should be shipped. That has to be approved by the CDC, but it's pretty much left to each individual state. And then those are shipped by the vaccine manufacturers to the designated sites in each state. Part of the reason that what we're seeing right now across the United States is really big differences from one state to another is that while the advisory committee on immunization protocols that advises the CDC makes recommendations for the whole country, which then the CDC director endorses, and those are put out, that really the ultimate decision-making authority is left to the states and to the state Department of Health and the health officer. So each state develops their own state plan. Although they send that to the CDC for review, you end up with what we have right now, which is a lot of variability from state to state. And then there is also some discretion that's left to individual organizations as well. So I just put as an example here, UW-Medicine has been a great earlier provider in our state, has been helping with this initial phase of getting our healthcare workforce vaccinated. And there's some discretion left to them about who to include in different tiers. There is guidance from the state, but so for instance, if you hear like your friend at Swedish got vaccine before you did, it is possible that there could be some variability from one provider to the next. Okay, so we had discussed Washington's COVID-19 vaccine plan back at our December 2nd webinar when a lot was still up in the air. And that is recorded and you can find it on our website and on YouTube, and we'll share the link in the chat box. But since then, a lot more details have emerged. So what I'm showing you here is the Washington DOH's new phased vaccine plan and a nice visual timeline that they've developed. The premise behind this plan is really summarized by that statement down on the bottom, which is this focus on equity. So as you're hearing on the national level, discussions about who should be, whether we should have large groups of people in early phases or we should be more limited for the early phases, and whether we should be trying to do these phases sequentially. Keep in mind that the reason that we have this sequential planning is that the goal is to make sure that those individuals who are at highest risk for exposure and highest risk for severe symptoms are vaccinated earlier. And specifically with this phase A1, A2, that we're taking care of those individuals who are absolutely essential to our ability to care for everyone else in society. So we are currently in phase 1A, which is focused on vaccinating our high-risk workers in healthcare settings, our high-risk first responders, and long-term care facility residents and staff. Last week, the DOH also released guidance for the next phase, which will be 1B or 1B1. And that will include all people who are 70 years or older, as well as people who are 50 years or older who are living in multi-generational households. Good news for both Seattle and Greater King County. The city of Seattle was approved this week by DOH to serve as a vaccine distributor and will begin administering vaccines to Seattle's residents and workers in the coming weeks. The Seattle Fire Department, as part of that initiative, has launched 2 mobile vaccine teams to administer COVID-19 vaccines to right now they're specifically focusing on residents in shared living facilities who are of an age where they are particularly vulnerable and where they're not getting service from federal programs. And actually, so Ashley tells me they will begin vaccinating tomorrow, Thursday, January 14th. In addition, King County announced $7 million in funding to create new community vaccination sites and mobile teams to efficiently and equitably vaccinate as many residents as possible, as quickly as possible. So as of January 8th, Washington State DOH reported that over 466,000 doses had been distributed throughout the state. Of those, 151,000 had been administered, which is actually slightly faster than the national average. And I'm going to turn it over to Tim because Tim is going to give you some information about both what the experience has been at UW-Medicine. My understanding is that they're one of the few sites that was really ready to hit the ground running when the first doses of vaccine were delivered and have been doing a great job. So they're one of the few sites that's really, at this point, limited by the amount of vaccine they're receiving as opposed to by their capacity to get it out. But nonetheless, I think he'll share with you some insights into not just some of the successes, but also what some of the challenges are that we're seeing so far. So with that, Tim, I'm going to turn it over to you.
Great, thanks, Hilary. And again, thank you for inviting me to participate here this afternoon. As Hilary mentioned, we started our planning through our Emergency Operations Center a couple of months ahead of when the FDA then did those emergency use authorizations, first for Pfizer on December 11th and then Moderna a week later. So a lot of work and planning had gone into this. It's a very complicated process with this vaccine. Hilary already mentioned the 2 doses and tracking people for that second dose, but also just the storage, as people saw, particularly with the Pfizer vaccine and the ultra cold temperature needed for storage, even for Moderna a little bit. But the logistics around this are much more complicated than our normal influenza vaccination campaigns. On December 17th, we really kicked off our campaign and focusing on those healthcare workers, both within our UW-Medicine hospitals and clinics, but also really committed to 20% of those doses being available for healthcare workers in our community, recognizing that a lot of individuals just simply did not have access to vaccination because of those logistics that we discussed. We were very pleased to see that by December 30th, we were able to actually offer vaccine registration to all of our healthcare workers within UW-Medicine. And as of today, we have, from a first dose, over 16,000 of our employees across UW-Medicine. So our 4 hospital campuses, as well as all of our clinics, have been vaccinated, and over 6,000 community partners have been vaccinated to date. Last week, we also started the second round already because the Pfizer dose, again, is only a 3-week difference. So we've set up 4 vaccine sites, 1 on each of our hospital campuses. I think the real question for us, and you alluded to, is really the supply. Right now, the way this works is, the state waits to find out from the federal government how much they're going to receive, and then they do allocation within the state. But we don't know how much we're going to get for the next week until a few days in advance. And so that makes it extremely difficult to do that planning. And so when you look at some of the numbers in terms of how many have been vaccinated, I think, if anything, that probably underestimates the total number, because I do think there's a reporting lag. This is, again, extremely complicated because for the hospitals, for non-employees, you have to be able to register them, get them tracked, track the doses, then do the reporting to the state. And so we've fortunately been able, with a lot of IT support, to be able to do that. But I think that has been one of the difficulties, is for those healthcare workers in the community that aren't directly associated with a large healthcare system. There's still a lot of people who have yet to be vaccinated. So we're really committed to trying to continue to do that. I think we're in an interesting phase as we get ready for 1B in terms of pivoting from hospital-based to community-based. And this is where I'm really excited to see the announcement from King County, from the city of Seattle. And again, we'll see more details, but their plans to establish mass vaccination sites is really going to be critical, because the hospitals will continue to support, but it has to be in partnership with these community vaccination sites to really get the volume and numbers that we need. People may have also seen HHS yesterday made an announcement about offering vaccine to people 65 years of age and older and underlying medical conditions. Again, the Department of Health, my understanding, is still evaluating this and determining what they may or may not change in terms of their rollout. And honestly, a lot of this depends on the supply. Hopefully that supply will continue to increase, and as those pipelines increase, then we can make it much more available to the community. In terms of our capacity, just as an example, we've been doing about 1,000 a day. We have the capacity to at least do 2,200. And as we pivot from our employees, we're looking to expand some of our sites to be able to meet some of those increased volumes as we start to offer that to our patients and our other employees who would be eligible based on those DLH criteria. The last thing I would just say, again, we are really working in partnership with Department of Health, Public Health throughout this pandemic, right? Whether it's been testing, practices, now with vaccination. It's important that we really stay in alignment in terms of how we do this to best serve our community. And I have to say, we are very fortunate to be here in Seattle with such strong relationships with Public Health and the Department of Health. And I'll pause there and see if there are any questions.
So I think we're going to hold questions until I'm going to say a few words about the roadmap to recovery, the new phasing, and then we'll switch over to questions. But thank you so much, Tim. Okay, so some really important reminders, and hopefully this goes without saying for our public health community, but you can help us to continue to message this out, that for the entire duration of this vaccine campaign, so that's likely the next 6 to 9 months at least, community level actions are still going to be required in order to control transmission of COVID-19. So that may not always include school closures and restrictions in terms of places of worship, but it probably is going to include, for an extended period of time, restrictions on large gatherings, like sporting events or concerts. And it's still, for a while at least, is going to mean that within those settings, as we start to open up different capacities, that maintaining social distancing and not having too many people within enclosed spaces is going to be absolutely critical. Likewise, all of those individual non-pharmaceutical intervention actions that you've all been taking are going to remain core to our approach to containing COVID-19, including that people who are sick need to stay at home, that people need to maintain physical distancing, people need to continue wearing face coverings, etc. So just as a reminder, please help us in the coming months. I think that's going to be really hard for people, particularly as they start getting vaccinated, to remember that they need to continue to be vigilant about these other activities as well. So with that, how will you know when restrictions are no longer necessary or when different things get lifted? So last week, Washington sort of pressed the restart button on our COVID phases. We now have new phases, and this new approach is called Healthy Washington Roadmap to Recovery. It's a great sort of refresh in that we've been able to capitalize on lessons learned from, issues encountered from the previous phasing. Under Healthy Washington, the state is broken into 8 regions. Our region, which is the Puget Sound region, includes not just King County, but also Pierce and Snohomish counties. So that's awesome because it means for the first time that all 3 UW campuses are going to be in the same phase forever, which is great. Just makes it easier for our planning. So that's awesome. Right now, all regions in the state are back at what is the new phase 1, which is very similar to the restrictions that we've had for, I have here for the last month, but it's been more than a month, that went into place in late November. Couple of things that are different about the new approach. One is that regions will move automatically to phase 2 if they meet 4 metrics. I'm going to tell you what those 4 metrics are. And also that there are specific metrics by which if they didn't continue to sort of meet the goals, that they would actually move back into phase 1. So when I say automatically, that means there's not this like petitioning to the Secretary of Health and to the governor to get permission to move. It's just once you're up on the website and officially, according to the track metrics, the region is ready to move, it moves. And we fully anticipate that there will eventually be 4 phases like there were in the last plan, but right now, what we know about is phases 1 and 2. So in terms of the metrics that are needed to move to phase 2, because of course, you know, here we are off to the races again. Of course, we want to know like when can we have fewer restrictions. They're just 4. It's really straightforward. The first one is a decreasing trend, a 10% decrease over a 14-day rate of new COVID-19 cases per 100K population. We're actually meeting that already in the Puget Sound region, so that's great. We're this sort of light yellow group. The one that we are not meeting right now, or at least as of Monday, is to see also a 10% decrease over the last 14 days of new COVID-19 hospital admissions per 100K population. We're a little bit above study right now. And then the last 2 we actually are meeting already for our region. The third one is average 7-day % occupancy of ICU staff beds needs to be less than 90%. And the Puget Sound region, we're already meeting that. And likewise, we are already meeting the requirement that the 7-day % positive rate for COVID-19 tests needs to be less than 10%. So it's really good ideas to keep track on the websites for DOH and the governor's office, checking those metrics to see how we're doing so that you know when we get to move to phase 2. And again, not huge differences between phase 1 and where we have been. I know this is a lot to read. And so what I'm really hoping is that you will go and look at this on the governor's website and help push out this great infographic that really very specifically calls out the differences between phase 1 and phase 2, again, based on the evidence that we accumulated over the last 9 months about what kind of activities really are the highest risk activities, and making sure that we are not engaging in those and more gradually ramping things up. The one big difference I would note between our current phase 1 and where we were a week ago is that some indoor recreation facilities, gyms, are allowed to do engage in some low risk activities. So I know there's lots of people out there who are like, woo, you may be able to go back to the gym depending upon what you want to do. Okay, and then I'm just going to end with, as we turn to questions, I wanted to share yet another infographic coming from the DOH and governor's site that we hope that you will continue to push out through your social media, which is that in order for us to be successful in Healthy Washington and being able to continue to move sequentially through these phases, we're going to need people to really adhere to the good practices that they've developed over the last 9 months. So with that, I'm going to stop sharing and we are going to turn over to our Q&A. Okay. So the first question, unfortunately, is not one I can answer. Maybe Janet will be able to answer it, or Tim. It's actually one I've looked into and not been able to get a clear definition of, which is Marilyn says, I've seen a lot of questions on social media about what constitutes a multi-generational family. How is it defined? So I know there's some differences depending upon are we going to go with the Census Bureau definition, or does DOH have their own definition? You know anything about that, Janet?
I love the question because I think it is really important for DOH to come up with their own explicit definition. I'm guessing they're going to be using the most common federal 2 or more adult generations in a household. But I actually wrote that down when I saw it so that I can ping DOH to make sure they know they need to define that in their FAQs.
Yeah, here's the latest, and I would say that this continues to evolve. But the latest that I've seen through WISHA and DOH conversations, and I'll read it because it's complicated, which also for us means it's going to be very challenging to actually implement from a feasibility standpoint. But 2 categories of people who are eligible under the multi-generational household definition. 1, people who are over age 50 and are not able to live independently, who either A, are receiving long-term care from paid or unpaid caregiver, or B, are living with someone who works outside the home. And then 2, people who are over age 50 and are living with and caring for a grandchild. So again, this is where it's at right now. I'm not saying that this will be the final, but this is the most recent information that we've received. And I'll just be honest, from a vaccination standpoint, it will be incredibly challenging to implement. We will take whatever DOH gives us and we'll post and make available for our patients and community. But there's no way that a vaccination site, we're not going to be able to monitor or check or validate that. So it gets back to what some talked about in terms of the honor system before. So it's going to be a little complicated. I totally appreciate their attempt from an equity standpoint, but it's going to be a little complicated.
Yeah, that's super helpful, Tim. And something you alluded to there, I think is something that we still are waiting to get more information about, which is sort of whether it's going to be purely an honor system. There was a release about a nice tool that DOH had developed where people could check to see whether they were eligible in the current phase, which is right now it's only phase 1A. And so that's a pretty easy one for people to figure out on their own whether they're eligible. And so I think people more want to know, when will I be eligible? And we're expecting an update of that tool. I think they said on January 18th. But I think some of that is thrown into a little bit of question based upon the announcement from the Trump administration yesterday that they were changing their recommendations in terms of distribution modalities. And so we're honestly just still waiting to hear back from the state. And I think the state is probably still evaluating what they're going to do in terms of that. And that will then play out in terms of who's going to be responsible for checking who's eligible and figuring all those things out. So stay tuned on that. Okay, so next question. Someone asked if we can address distribution in the Tri-Cities. I don't have any information about that. Janet says no as well. And I actually haven't checked any of the websites for local health jurisdictions other than Public Health Seattle and King County. I have to say, I told Tim, I obsequiously praise our practice partners at every chance that I get, but I love the Public Health Seattle and King County COVID vaccination site. It's really good. It looks like they're going to have information up there about how to, once the phases start opening up, how to figure out whether you're in that phase, links to that tool, and also information about how you get an appointment. That's all still TBD. I just don't know about other local health jurisdictions, but my recommendation would be to check on the website for your local health jurisdiction. And if you don't have anything there yet, to then check with Washington DOH and their website. And again, we will distribute the slides with the links to those. Did you want to add anything, Janet? No, okay. So from Leslie, a comment that personnel seems to be a bottleneck in this rollout. And yet retired nurses have been told no, which I hadn't heard of. Is there a way to leverage these people resources by offering a day-long training and certification to those with skills but expired credentials? This seemingly would allow us a better opportunity to speed the process up, for instance, holding 24/7 vaccination clinics. I'd love to hear from both Janet and Tim about sort of what they're seeing as being the bottlenecks. My sense is the bottleneck, right? I think we will get to a point where personnel is a bottleneck. My sense right now is that the bottleneck is more, with the exception of entities like UW Medicine that were working on this pretty far out ahead of time and also had a system in place. That with most places, it's more dealing with the sort of logistical challenges and figuring out how to deal with the constraints that they face, that we haven't yet hit to the point where it's a personnel problem. But I'd love to hear from you guys in terms of what you're seeing.
I think that's right, and particularly supply. We don't have enough supply to do 24 hours a day. The other thing, we thought about that briefly with our own employees, but you have to have a steady volume of individuals that you're vaccinating, because once you open one of the vials, right, then it's say 5 or 6 doses in the Pfizer vial. And if you don't have enough people, then we don't want to waste it. And so that was one of the challenges in the middle of the night. So I think we need both supply, and then maybe personnel will become an issue, but it's also then the logistics. So we don't want to waste any vaccine. And so we need to ensure that there's a constant stream of people who would be vaccinated in that setting.
Yeah, I'll just support Tim in that comment. I think though that if we're going to be optimistic and the way that Biden is being optimistic and thinks that we're going to get a lot more supply coming up really soon, we need to be thinking about Leslie's question now. So I believe they are. I'm just not sure whether we'll be able to kind of staff up and get everybody trained and all the communication that needs to go in both, with the providers and with the public in order to kind of stay aligned with as supply increases, so we can move this along as fast as possible. So I think it's a really important question that Leslie is posing. And I don't know specifically about this population, but I know that the Department of Health is thinking about how to bring in folks who can help from the community, different groups.
Okay, our next question is actually something I'm not familiar. So it said there's been talk of cutting doses in half to provide more doses, and then asking about the efficacy of a half dose. I hadn't actually heard that. What I had heard was a talk of delaying second dose. But Tim, do you want to address that?
Yeah, let me, I think both of them, whether it be moving to a single dose or a half dose, the whole idea is how can you spread the vaccine further? And again, I think it's more, when we say supply, it's not that there's not supply that's being manufactured, it's the distribution. It's getting it from where it's being made to the areas where it's being injected and administered. So it's the distribution that we really need to move. The FDA actually, when these questions came up, both appreciated, these are things that we need to think about. But on January 4th, they actually put out a letter really strongly discouraging that, because these vaccines, at least in the phase 3, were really studied with a 2-dose process. When you look at the Pfizer vaccine as an example, after 1 dose, it was 50% protection in a small number of individuals, but then 98% of individuals in that study went on to get the second dose. So we really don't know with 1 dose how durable and long that protection, even at 50%, would be. So I think it's something that, needs further evaluation. And I know there are some groups that are going to be looking at that. But right now, based on the evidence, the FDA is still recommending that we vaccinate based on the emergency use authorization, which was the 2 doses.
So our next question, I think I know the answer to this, but chime in at either of you guys if you know otherwise, is who's orchestrating or leading the mass vaccination efforts? And for us in King County, that is Public Health Seattle and King County, I think jointly with City of Seattle. So City of Seattle already had an existing partnership with UW-Medicine for their testing sites, and they're the same groups that they're leveraging, and again, leveraging that partnership with UW-Medicine. And both of them are talking about both some sites where they could bring really large numbers of people through in a relatively short period of time, and also mobile units as well to get out into communities that don't have great access.
Hilary, I just wanted to add that I don't think we're done figuring out who's going to be helping with the mass vaccination. And, some public health agencies across the country, including here, are calling on the federal government to help with standing up mass vaccination, which they've done before. I think it's really great that our local folks are already planning for this, but I think we need more. And hopefully we'll get some additional support for that.
Yeah, really good point. So Tim, here's one that you may be able to address, which is what the refusal rate has been for the vaccine so far, what you've experienced in UW-Medicine, and again, knowing that this is healthcare professionals at this point that we're talking about.
Yeah, our declination rate has been 8.7%. So we've actually been really happy with the uptake thus far. Now, with that said, we have had pockets of our population, such as our environmental service workers, where the declination was more in the 30 to 40% range. And so we've really been developing town halls and messaging for individuals who have limited English proficiency, communities of color, particularly where there may be mistrust of some of the vaccine, or we just need further information. And I think this is going to be extremely important as we move into the community at large as well, because I fully expect that the declination rate in the wider community is probably higher. And so we really need to partner with communities and build that trust around the vaccine. The last thing I'll say is, interestingly, of half of those that declined, half of them did say they would take it later. They just wanted more information. They wanted to just watch a little bit, make sure it was safe, and then they would consider getting vaccinated later. So it wasn't an outright no, but it was just like, I want to wait a little bit.
Yeah, so I think those are really good rates and something to be very proud of. I have been hearing anecdotally from folks in other regions that the declination rates are higher or refusal rates are higher even for healthcare personnel. So, and I agree with you for sure as we get out into the community. So I just want to give people a heads up. We are trying to organize, I don't know if it'll be 2 weeks from now or 4 weeks from now, but one of our upcoming webinars to talk about vaccine hesitancy in more detail, and also about some of the strategies that folks are using there. Our next question from Chuck, hi Chuck, is that is there any new information about whether or not people who have been vaccinated could still be spreaders of SARS-CoV-2?
Yeah, I think it's a really good question. We still don't totally know, meaning that the studies, particularly the Pfizer study, looked at, did you develop symptomatic disease? Did it protect against that? We don't have as much information. I think it'll come out in terms of the impact on transmission, as well as asymptomatic infection. So right now, if you are vaccinated, you still need to physically distance, wear a mask, all those same protections, because we don't know, could you have potential virus in your nose that's still replicating, then transmit it to others, even though you yourself never developed disease. And so I think hopefully we'll learn more in the near future, but for right now, being vaccinated really doesn't change how you should behave in our overall approach as a community.
Janet, this may be one that you know the answer to. Here from Sarah McKenzie asks, she points out that the 4 new indicators no longer include the CDC indicator of influenza-like illness or COVID-like illness tracking. And she's sort of hypothesizing, is that because we have enough testing and feel like that's not an important indicator anymore? Do you know how they came down to those 4 indicators from the gazillions of indicators that we had previously?
Is this for the governor's?
Yeah, for the Healthy Washington, the 4 metrics to go to phase 2.
Yeah, I don't know how they came up with them, but you know, your hypothesis is a good one, Sarah. I'll come up with something and ping you later.
I can say there were a number of conversations between the governor's staff, Department of Health, Washington State Hospital Association. One of the things I think when you look at those metrics, they're very concerned about the healthcare systems being overwhelmed. And so there's a part of those when you look at, right, ICU capacity, admissions, they're looking at what's happening within the community in terms of new cases, but also how are the healthcare systems and do they still have ongoing capacity? So I think they were trying to incorporate a little bit of both.
All right, here's next one I do not know the answer to, and I actually hadn't even noticed, but maybe one of you guys knows. So in the new Healthy Washington phase 1, someone picked up that there's a difference, which is that until January 11th, from end of November through January 11th, social gatherings, indoor social gatherings were prohibited with people from outside your household unless, unless you had been in quarantine for 14 days prior to the social gathering, or quarantined for 7 days prior and received a negative COVID test no more than 48 hours prior to the gathering. And those sort of additional loopholes, if we could call them, have been eliminated from what the person could see from the summary table. Do you guys know if are they really no longer being used, or what the deal is with those? Anyone know? No. Okay, we'll have to look into it. It might just be that it's not in the summary table. That's possible. So, okay. Here's a question for you, Tim. Todd asks, how do you track first and second shots?
So our IT people have done a phenomenal job that when we invite someone to be vaccinated, our employees, they go online, they can literally pick whatever time and date they want, and they can see what's available and works with their schedule. Once you do your first dose, it immediately goes to the appropriate timing for your second dose. And so you register for both the first and second dose at the same time, even before you receive the first dose. And so we've done that with our employees, and for our partner healthcare workers, they can call a phone number, and we do the same thing. So we get them their first dose scheduled and their second dose scheduled right up front.
Yeah, Tim, I mean, I think, from what I can tell, some of the reasons that UW-Medicine has been so successful in terms of rolling things out, as you indicate, has been that you had, really great IT systems, not just for appointments, but also, we're ready to go in terms of the registration issues and, the tracking people. So my sense is that is going, as we shift from this more specific population to the larger population, and also have other sites doing vaccinations, that those logistics are going to be probably challenging. I just see a nod. He didn't disagree. Okay. Kudos to UW-Medicine though.
You know,
Okay.
the one thing I was thinking of, you know, with the testing and the city sites, they use the Solve software where you go online and register. And I don't know whether that could be, again, modified so that when you go online, register, that you pick your first dose and you pick your second dose. So I don't know if they have that capability. That would be ideal. But otherwise, it is challenging if we only appoint the first and then leave it up to the individual. We have to, I think, really go out and proactively bring people in for that second dose.
Agreed. Okay, we have a question from Doris who asks, when will a person age 65 to 70 be allowed to get the vaccine? I don't see a category for this age group. Well, that's a great question and is one of the ones that I would say is up in the air right now, given the announcement from the federal government yesterday. So it wasn't until one of the later B phases that, and it would have been specifically individuals who had comorbidities that would have been in those earlier phases, and whether or not that's going to change now with the change in federal guidance, or the suggestion that the federal guidance is going to change, because I don't think the CDC website's been updated with, and the written guidance hasn't been issued. That I think that's a big question mark. So it really depends. Oh, question on guidance on the definition of comorbidities. I'm pretty sure that DOH has stuff up on their site. Tim, do you know?
Yeah, I think if you go to the DOH website and you actually look at the detailed document, it does list out those. I remember seeing it somewhere on there. So I think go to the DOH site and look there. And they try to identify those that have been associated thus far with worse outcome.
The next question was, phase B3 of the vaccine distribution states it includes people 16 years or older with 2 or more comorbidities or underlying conditions. Question is, does that mean that you must have 2 underlying conditions to qualify for this prioritized group? I think it's, you need to have 2 underlying conditions that are associated with higher risk of severe symptoms for COVID. So 2 conditions that are on that list. Charles, hi Charles, says, do you have an update of whether we are going to prioritize giving as many people as possible 1 dose of vaccine versus the 2 doses recommended by drug companies? What level of immunity will this confer? It wasn't tested in the trials. So I'll give you my prognostication, then I'll let Tim tell you his more informed version, or Jana. My sense has been that it doesn't seem like the FDA is leaning towards that anytime soon. So although there's a lot of talk about it, it would surprise me that it happens in the United States anytime soon. That's sort of my guess. I've heard some really interesting stuff from the folks at the Institute for Disease Modeling. You're right in terms of the problem is that all the people who were in the trials got 2 doses, but we have this like narrow window of data between day 12 and day 21 when they could get the vaccine, first dose of vaccine was working, and they hadn't received their second dose yet. You can compare infection rates for that group versus the control group. That's not exactly how they calculated the efficacy of 1 dose. I think they calculated based on from day 1 to day 21. So the folks at IDM actually thought, when I was talking to them, suggested they thought it was actually better than it's been advertised in terms of the 1 dose efficacy, but it may be a moot point because the government doesn't seem inclined to go that way anyway. But Tim, go ahead.
Yeah, no, that goes back to that FDA letter that I mentioned earlier. I think they're still recommending the 2 doses. Again, if we get more information or data, but I think they're unlikely to change right now. What will be interesting is the Johnson & Johnson vaccine, which we hope the phase 3 will conclude at the end of this month. And if that goes to the FDA in February, that is a 1 dose regimen. It's an adenovirus vector, so it's a different technology. We'll have to look in terms of comparable efficacy, but even with some of our patient population, for instance, where we think a second dose or ensuring that they may return for a second dose may be a problem, the Johnson & Johnson could be a huge benefit. And I also think it's going to be a lower cost. So if you look at around the world, I think there's a lot of hope around that being a major player with one dose, lower cost. So I think this is going to continue to evolve as we get more vaccine options as well.
I just wanted to add, Hilary, to Charles's question that, I fear a little bit there's been like this false equivalence set up, like, oh, we need to reserve all these doses to make sure everybody gets their second dose in time. And what they've done in the UK is not what we want to do here, which is have people delay their doses. But I really like what Biden said last week. And he said, we're going to release all the doses and we're going to step up manufacturing. And we're just going to make this happen because the first priority needs to be, we need to get this out fast and, start getting the ball rolling instead of sitting on all the supply. So I think, ideally, if we can get to that both and place, that's really where we want to be.
Really good point, Janet. So we have 4 minutes left. We have an incredible number of questions. I think what I'm going to do, you guys are welcome to look at the questions if you want to, but I'm going to give you guys the option of picking a question that you would like to answer or that you think we haven't addressed yet, that you think is a particularly important one that lots of people are going to want to hear. So while you're looking at those, I'm going to talk about the next one, which was someone asked whether or not, for instance, residents in the Greek housing off campus would be included in group B4, 1B4, because it said congregate living facilities. And I actually hadn't noticed that. I thought that there was some like comorbidity thing that was linked to that. So I'm going to look into that because that could actually be really important for our dorm residents as well and could have really important implications for bringing more students back to campus. So good question. Don't know the answer. Tim and Janet, when you're ready, raise your hand. If not, I will go on and answer. No. Okay, Tim, it's you.
So I want to answer, there's a question around pregnancy. And this is, I think, a really important topic. And the individual who asked the question is absolutely correct. Pregnant women were not included in these studies. There are ongoing efforts to change that. But right now, absolutely, we don't have direct evidence from those studies. At the same time, if you look at the Society for Maternal Fetal Medicine, ACOG, which is the National Society for Obstetrics and Gynecology, as well as our local obstetric experts, they all recommend that if you are in a high-risk category and pregnant, that you should be offered the vaccine. Ultimately, it comes down to a decision with you and your provider, but they do believe when they look at the risk benefit that the risk of worse outcome in pregnant women who get infected with COVID-19 suggests that they should be offered the vaccine. So that's what we're doing with our healthcare workers who are pregnant. I would also say that it is a common reason why people may defer and wait, which again, I totally understand, but there are statements from the national societies really supporting at least offering vaccination to high-risk pregnant women because of the impact of COVID-19 on pregnancy.
And I'm ready to, Hilary. I'd like to take Dave Grombowski's question. Hi, Dave. The question is, to boost vaccination rates, what do you think of employers giving employees paid time off, such as through paid sick leave to get their vaccinations? And what I wanted to say about that is, this has been an issue in this country related to encouraging, isolation and quarantine and the lack of people, getting support from wherever the support could come from to encourage people to stay home in order to keep the pandemic under control has been a problem. So, I answer this in the context of that. And, I'm only speaking kind of generally, not as like a UW anything, but what I'll say is that, and I say this regularly, and I know it like drives people crazy because the vaccines are very exciting and I'm excited about it. But if we do not get enough people ultimately down the line to get these vaccines, we will not meet our societal objectives, which are kind of the functional end to this pandemic. So whatever we can do organizationally and through communications and through making it accessible and easy for people will be a win for all of us.
And as moderator's prerogative, I'm going to take a question that sort of was hinted at in one of these questions, but is a point that I think is really important because, which is that the paradigm for distribution of this vaccine is really different from the paradigm for distribution of our routine vaccines. And so I think most people think of, oh, I want to get vaccinated. I'm going to find out from my primary care provider and I'm going to go to my primary care provider. And because of some of the logistical reasons that Tim talked about, and just because we're trying to get it out to so many people in a short period of time, having dedicated facilities or mobile units or sites that are just doing COVID vaccination is probably the way you're going to see this rolling out for much of the next coming phases. So it's just a different mind shift. We are trying to remain cognizant of that as an employer, and I'm sure other employers are as well, which is that you may not get an email from your primary care physician saying, hey, you're eligible, go find a place. But we as a school are committed to continuing to push out to you guys information about who's eligible and where the resources are that you can go to find out how, locations for getting vaccine sites, how to figure out if you're eligible now, and how to sign up for an appointment. So we will continue to push out that information, but I would also really encourage folks to continue looking at the Washington DOH site that we provided for COVID vaccines and for Public Health Seattle and King County's COVID vaccine site for information about who's eligible at that particular date, to figure out if you're eligible, how vaccine is being distributed and by whom, and how you sign up for an appointment. So those are all things that we will continue to push out to you, but want to strongly encourage people to be proactive and looking for that for themselves as well. So with that, we have hit 4:02. Any final words, Tim and Janet, other than huge thanks to both of you. It was great to have both of you here.
No, thanks for having me. That's been terrific.
All right, thanks guys. And thanks everybody who tuned in, and sorry that we didn't get to everyone's questions, but hopefully you'll be able to find out more information on the sites. And like I said, we will follow up with relatively soon a conversation about vaccine hesitancy. Take care, everybody.